Welcome back, everybody. So in this next video, we are now going to talk about something called acute interstitial nephritis. Sometimes this is also called tubulointerstitial nephritis. So really these are kind of used interchangeably and they mean the same thing more or less. So first I want to talk about, what does this mean, interstitial nephritis? So if we think about the kidneys, we have millions of little units inside the kidney, which I'm highlighting here, called nephrons. These nephrons are going to encompass our Bowman's capsule, our glomerulus, and it ultimately allows for filtration to occur throughout the renal tubules, through the collecting duct. We reabsorb things that we want in the body, we secrete things that we don't want in the body, and ultimately we excrete things in the urine as the final step of this process. The interstitium is essentially all of the areas that surround these tubules, surround the structures, right? So when we say we have interstitial nephritis, we're talking about stuff outside of the tubule that gets inflamed. Or as you can see down here in our diagram, right, these dark pink areas are representing inflammation. The white circles are kind of the inside of our tubules, our tubular lumen, and everything around it can get inflamed. So that's the actual interstitium of the kidney. When we say acute interstitial nephritis, we're talking about the extracellular matrix and the fluid that surrounds the tubules. So with that in mind, we're going to start talking about our pathophysiology here. And the first thing I want you to keep in mind is that tubulointerstitial damage is typically a type 4 hypersensitivity reaction. And do you recall what a type 4 hypersensitivity reaction is? That's right. They're a type of delayed or cell-mediated reaction that typically involves T cells. This is typically broken up into two key steps where we have a sensitization phase followed by a response phase that occurs after repeated exposure to something. This is very commonly seen in drugs and medications, and this is why we see it so much in acute interstitial nephritis. Now, this can also be associated with tubular obstruction or a blockage in the tubules, or inflammatory infiltration. And this makes sense, right? Because this is a nephritis, this is an inflammatory process. So when we talk about the key etiologies here, far and away the most common cause of acute interstitial nephritis is going to be a medication reaction. And we break this up by using a memory aid, which is the 5 Ps. The first of which is painkillers. So the classic one that we use for patients is going to be NSAIDs. So if a patient presents with a chronic history of NSAID use and they have kidney problems, there are a variety of things that can be going on, but one thing that we want to keep on our differential early is acute interstitial nephritis. The second P stands for P-pills, and this is classically going to be presented as a diuretic. So if a patient is on furosemide, which is a very commonly used loop diuretic, they can present with this presentation as well. And this ties back into what we said about our type 4 hypersensitivity reaction. The patient takes the medication at first, T cells get sensitized, and as they repeatedly take the medication, now we're getting an inflammatory response or a type 4 hypersensitivity reaction. The third P that we want you to know is that of penicillin. Now, there are a variety of different antibiotics that can actually cause this, including cephalosporins, sulfonamides, beta-lactams, fluoroquinolones. But for the sake of this memory aid, the 5 Ps, penicillin is the easiest one to remember. However, keep a little bit more of a general overview with this particular P. It's not purely penicillin that can affect it. It's the subgroup of a variety of different antibiotics. The fourth P that we want you to know is PPIs, or proton pump inhibitors. A classic one that's used in question stems is that of omeprazole. And the fifth P of the 5P memory aid is going to be rifampin. Rifampin is an anti-tuberculosis drug. So this might present in a question stem where they give you a presentation of a patient who has immigrated to the United States from a different location. Potentially, they will tell you that this location has high case rates of tuberculosis, indicating the patient might themselves also have tuberculosis. They can be on a variety of different drug medication regimens, some of which would include rifampin. So if they are presenting and now they have kidney symptoms, you need to look at their medication list and see, are they taking any of these anti-tuberculosis drugs, specifically rifampin, which we know is associated with acute interstitial nephritis. So those are the 5 Ps, and then the apostrophe S is to stand for sulfa-containing medications. There are a variety of different sulfa-containing medications. These include things like sulfamethoxazole and sulfadiazine, but there are several other ones as well to be mindful of. Now, although medication reactions are the most common things to cause acute interstitial nephritis, there are some other things. A.I.N. can also be secondary to infection, which can be either a bacterial infection, viral infection, fungal, or parasitic infection. So I don't really want you to memorize any specific bugs because, quite frankly, there's too many to really remember. The classic ones are going to include things like E. coli, Campylobacter, Streptococcus. For viral causes, we have things like HIV, EBV. For parasitic causes, we have things like toxoplasmosis. But the point is that there's really a long list of things that can cause this. So I want you to just keep in mind this general idea that A.I.N. can be triggered by an infection. So if you have a patient presentation where their signs and symptoms are consistent with an infection, and they have some kidney problems as well, I want you to be able to keep in mind that there are a variety of different things that can cause A.I.N., which can be an infection. It's unlikely we need to know the specific ones, but we do need to have a general idea that they can lead to acute interstitial nephritis. And the last one I want to talk about here is that this can also be secondary to infiltrative and autoimmune diseases. Some of the classic ones they might ask about include multiple myeloma, lupus or systemic lupus erythematosus, sarcoidosis, and Sjogren's syndrome. So I think that a good way to prepare for board exams is to have a general idea of what is expected for us to know. I think it's expected for students to know that medication reaction is a very common cause of acute interstitial nephritis. I think you can stand out and get questions right that other people will get wrong if you can really dive in a little bit deeper and think about some of the secondary causes that can actually lead to A.I.N as well. Because if they ask students about interstitial nephritis with a medication, they might expect most students to get it correct. But if they ask students about acute interstitial nephritis with some of the secondary causes, they can really kind of evaluate which students have taken that next step, that second or third step into diving into pathophysiology, the causes of these diseases. And that's really going to help you get points on test day that someone sitting next to you might not get. So always try to keep that in mind when you're studying. Think about that second and that third cause of each pathology. Next, I want to move on to our presentation. So one of the classic findings associated with acute interstitial nephritis is this morbilliform rash. And this essentially means that the rash resembles that of measles. Here is an image of it right here. I'm highlighting in green so you can get a general idea of what this might look like on a patient's presentation. A classic place for it to occur is on the back, but it can also occur on the arms, the chest, and various different regions. But I just want you to be familiar so that you've seen this image if it were to show up on test day. Some other classic presentations that the patient might have include a fever, hematuria, or pyuria. Specifically, sterile pyuria. Sterile pyuria is basically saying that on a urinalysis, patients will have significant amounts of white blood cells or leukocytes. However, there's no actual sign of infection or there's no evidence of bacteria on a standard urine sample. So it's sterile because there's no obvious bacteria or infection present on the sample. However, it's still pyuria because there's still white blood cells in the urine. Now, key point here, this doesn't necessarily mean that the patient doesn't have a bacterial infection, as there are a handful of things that can cause sterile pyuria, such as chlamydia being the classic one, but it's a way to kind of narrow down our differential. If we see sterile pyuria, we're saying, okay, there's either no bacterial infection with white blood cells, or there is a bacterial infection. However, it's one of the bacterial infections that does not present on the urine sample. It's not readily apparent on a standard urine culture or urine microscopy. Some other key findings might include flank pain or costovertebral tenderness, CVA tenderness. However, it's also important to note that this condition can potentially be asymptomatic. Remember, we talked about with the acute kidney injuries that they can also present asymptomatic, but as they get progressively worse, symptoms tend to develop. Same thing applies here. Patients can have a very mild case of acute interstitial nephritis. As it gets worse, symptoms can eventually develop. Now, when we look at our diagnostics, we're looking at a couple of key things, one of which is going to be the concentration of our urine, or our urine osmolality. And we're saying that it's going to be about less than 350. Now, if you think back to your acute kidney injuries, what type of acute kidney injury is this most classically representing with a urine osmolality of less than 350? That's right. This is most likely to be an intrarenal acute kidney injury because we know in intrarenal we have damage and so we're not able to bring back our sodium, our urea, or our water, leading to a more dilute sample in the tubular lumen. Another diagnostic test we can use would be a blood sample. So this is going to show an elevated BUN with an elevated creatinine because we have damage to the kidney, right? It's not filtering things appropriately. However, we can also see eosinophils, which is a type of white blood cell that we could see in the urine, indicating our interstitial nephritis. Now, I think it's worth noting that sometimes students kind of use eosinophils in the urine as kind of a classic telltale sign that we're dealing with acute interstitial nephritis. And I think for board purposes, sometimes there is that pretty strong correlation with it. However, it's also important to know that in real clinical practice, purely looking at urine eosinophils and making a connection with acute interstitial nephritis actually lacks sensitivity and specificity. And thus, while it's a good thing to use when you're working up patients to consider, it's not really enough to make a diagnosis by itself. This is why we must consider everything we have available to us, including the patient's history, their exam, in addition to the lab findings. Other diagnostic tests include urine tests. So again, we have that term sterile pyuria here. So this means that there's white blood cells in the urine. However, there's not necessarily the presence of bacteria. We can also see white blood cell cast, microscopic hematuria, and mild proteinuria. So these are all things that we would expect to see in any kind of kidney damage, right? You can start to see some red blood cells potentially, some protein potentially, but the one that we most commonly give you in question stems as a clue is going to be the white blood cell cast. Now, keep in mind that there are a variety of different casts that can actually present in acute interstitial nephritis, such as waxy cast, red blood cell cast, but for test-taking purposes, that's the one they most commonly will give you, so that's the one I want you to keep in mind first. However, again, have that general overview. Yes, it's most commonly going to present as white blood cell cast, but not always. It can present as other casts as well. And the final diagnostic thing to do, the real definitive diagnosis, would be to get a renal biopsy. And in that renal biopsy, you would see what we've showed over here, where you get this kind of dark pink matter on the outside, and this is indicative of the interstitial nephritis. And finally, to wrap up this video, we're going to talk about management options. So the classic one is going to be supportive care. we said for a lot of these kidney injuries, we can't actually treat them with one specific thing, right? We're really trying to help the patient manage their symptoms until the body can kind of heal itself. Because this is a subtype of an acute kidney injury, specifically an intrarenal acute kidney injury, we want to do similar things. We would want to stop medications that are causing damage to the kidney. So cessation of causative agents. We would also want to manage underlying diseases, right? If the patient has an infection, we want to treat that infection. If the patient has infiltrative or autoimmune diseases, we want to help with symptom management of those conditions. And finally, we can also consider the use of glucocorticoids if indicated for the patient. So a classic patient presentation might include the question writers telling you about a 6-year-old patient who presents to the clinic. They were skiing 2 or 3 weeks ago. They twisted their knee really bad, and it's been in a lot of pain. Since that time, they've been taking over-the-counter anti-inflammatories with only mild improvement in their symptoms. Now the patient is presenting with a rash on their back, and they want you to take a look. The clinician also decides that they want to order some labs. They get some serum labs done, as well as a urinalysis. The serum labs show an elevated BUN and creatinine for the patient, and the urinalysis actually shows eosinophilia. So this is a classic presentation where we have a patient who has had a triggering event that led them to take anti-inflammatories for an extended period of time. We know that NSAIDs are a classic thing that can cause acute interstitial nephritis. Now, several weeks later, after taking anti-inflammatories, the patient's presenting with this classic rash on their back. You make this connection that they've taken a medication which has led to an allergic reaction. The labs are further confirming this with the elevated BUN and elevated creatinine indicating some kidney involvement. And eosinophilia in the urine is again giving us another clue that we are dealing with acute interstitial nephritis. And finally, just to wrap up this video real quick, I'll talk about some of the high yield points I want you to take away from this. So, acute interstitial nephritis, it's a type 4 hypersensitivity reaction. It's a delayed T-cell mediated reaction. It can be due to a variety of different things, the most common of which is going to be medications. Remember our memory aid, the 5 Ps, painkillers, P-pills, penicillin, PPIs, rifampin, and sulfa medications. It can also be due to some other things, including infections and infiltrative or autoimmune diseases. When we're thinking about the presentation here, we really want to be on the lookout for a rash, along with some less specific findings like fever, hematuria, or kidney involvement. It's also worth noting that with most of our AKIs, patients can actually present asymptomatically if they have a mild case, and that same rule applies here. When we look at our diagnostics, we're dealing with an intrarenal acute kidney injury. So acute interstitial nephritis is a subtype or a subvariant of intrarenal AKI, and that's why our urine osmolality is going to be less than 350, indicating dilute urine in the tubules. We can also do some other tests such as blood tests or urine samples, and the 2 key points I want you to keep in mind for this condition include eosinophils and white blood cell cast. Finally, when we talk about management options, we're going to be doing a lot of supportive care and discontinuing the causative agents, right? That's the easiest thing we can do. If a patient is taking a medication that's triggering their symptoms, well, if we can stop that medication, maybe we can get the kidney to improve on its own. If things continue, we can consider things like glucocorticoids, and always, we're going to aim to treat the underlying condition in these patients.